afternoon. My name is Melinda Isbell. I'm a registered nurse from the North Alabama area, and I would like to take a moment to share with you tonight a paradigm case study that I was previously involved with. I do certify that I'm the original author of this assignment, and any sources I used have been cited. Nothing in this assignment violates the plagiarism policy of Athens State. Before we dive into this particular case study, I'd like to just review for you the definition of a paradigm and how it relates to a nursing process. According to an article published by the Open Journal of Nursing, the word paradigm is defined as a set of acceptability of the different agents in a field. This acceptable set provides a framework that is not only useful to solve problems, but is also useful to regulate a series of studies in a particular field. What that means for us in everyday language is a paradigm is a set of beliefs that is generally accepted by everyone in our organization or group. The nursing paradigm is slightly more specific in that it considers the goals and parameters an organization sets as the base where quality care starts. Building on the foundation of goals like patient advocacy and personal growth, and parameters that include nursing education and a positive work culture, we can reach our positive healthcare objectives of transferring knowledge and improving patient care. Oftentimes, there's a shift that occurs in a paradigm when we as nurses encounter a case where we feel like improvements can be made. One such case occurred for me about a year ago in the emergency department where I am currently working. I had only been a nurse at this facility for a few weeks, and it was my first experience out of nursing school in an emergency care setting. Mrs. A was a 48-year-old female who presented to our emergency department with multiple stroke-like symptoms. The story was that she had not been feeling well earlier in the day and had told her husband she just felt like she needed to go lay down. After waking up from her nap, Mrs. A states that she was experiencing extreme right-sided weakness. Her husband noted, as did I on exam, that she was experiencing significant slurred speech and also a delay in answering her psychosocial questions. In the emergency department, we do initial assessments very quickly. So while I am assessing Mrs. A for deficits and obtaining a brief health history to evaluate for possible causes of her symptoms, I am also obtaining vital signs and drawing blood for not only laboratory testing but bedside testing as well. Using my critical thinking skills, I want to know what her fingerstick blood sugar is to rule out a hypoglycemic episode. I also need to know if she might be hypotensive, and I need a creatinine level to evaluate for the safety of potential CT imaging. My initial concern when all of those assessments were benign was a stroke. By this time, our physician is bedside and a code stroke was called. Calling a code stroke means an overhead page goes out to let our imaging department and our supervisors know that we potentially have a stroke victim in the hospital. Mrs. A was taken to CAT scan very quickly for imaging of her brain and then was returned bedside with her family. Now, up until this point, I feel like there was very much an acceptable set of beliefs among all of the healthcare providers involved in Mrs. A's care. Mrs. A's vital signs continued to be stable. She was able to respond verbally to questions. She was alert and oriented, but still drowsy, and continued to experience her slurred speech. Surprisingly, however, her CT scan came back normal with no signs of a stroke at all. After some time went by, even though she was showing signs of slight improvement, but still dizzy and emotionally upset, the treating physician let this nurse know that he personally felt like Mrs. A was faking her symptoms. It was at this point that I felt like the paradigm shifted, and he and I had very differing opinions on the direction Mrs. A's clinical care should take. Mrs. A was placed for discharge home with instructions to follow up with a neurologist. Provision 2 of the Code of Ethics for Nurses states that a nurse's primary commitment is to the recipient of nursing care, whether that's an individual, a family, a group, or a population. The Code of Ethics also commands that I advocate for the right and safety of the recipients of my nursing care. In this circumstance, I felt like my patient's safety would be compromised by her discharge home. My patient also maintained her right to autonomy in this situation, and she expressed to me that she was not comfortable with that discharge. I felt like it was my obligation to advocate for inpatient admission and evaluation. Fortunately for everyone involved, I do have a collaborative relationship with my physician, and because of our mutual respect for one another, he reconsidered Mrs. A's discharge and she was admitted for further workup. At the time of this case study, I would like to think I was demonstrating confident nursing skills. Although I had only been a nurse for 1 year and was inexperienced in the emergency room setting, I do feel like I recognized the seriousness of the clinical situation. I feel like I was able to anticipate possible orders and treatment plans. I also feel like I trusted my gut when I went to the physician and advocated against discharge. As I read about Dr. Brenner's stages of clinical competence, I know that my previous experience on a medical surgical floor allowed me to recognize concerning patient symptoms. I also feel like my experience working as a nurse up until that point had given me confidence to trust my patients and confidence to trust myself on the rare occasion that I felt like a physician should be challenged. So what happened? Oftentimes, we don't have the luxury of follow-up reports from the patients we see in the emergency department. I did know that Mrs. A was admitted to our facility for a neurology evaluation. A few days later, I was called to the triage office because someone wanted to speak with me. Turns out it was the husband of Mrs. A, and he had stopped by to thank me. Because of my insistence that Mrs. A stay for evaluation, it was determined that she had a seizure disorder and had experienced an atypical seizure the day she visited our emergency department. It felt really good to know that my actions helped to solve a piece of this really scary puzzle for her family. This experience increased my confidence and also my respect for my physician, who was willing to put aside his pride and listen to the voice of a patient advocate. Thank you for your attention to my presentation of this paradigm case analysis.